Grand Rounds actually will be in September, so I think that's kind of a nice respite, and I hope everybody has a very safe and uneventful summer. So I will introduce our division chief, Dr. Don Miller, the chief of the Division of Hematology Oncology, who will be introducing this morning's speaker.
So I guess last but not least, I'm pleased this morning to introduce one of our outstanding young faculty. Adam Rojan has been here for a year and has just done an outstanding job. He is a Midwesterner. He grew up in Illinois and then went to college and medical school at Brown, did his internal medicine training at Penn, and then went to the BI in Boston for his fellowship. We were pleased a year ago to recruit him here, and he's just done a great job in building a clinical practice. He's interested in GU cancers and in benign hematology and has an expertise in thrombosis, and is going to talk today about thrombosis of cancer. And I told Adam that the last time I heard a grand rounds on this topic was about 30 years ago, so it's probably overdue, and I think we'll all be interested to hear what he has to say. Adam?
Thank you for that. Let me just turn this thing on. Again, I just wanted to thank you for the opportunity to speak today. What I wanted to cover was some aspects of cancer-associated thrombosis. In this talk, I'd like to discuss mechanisms of hypercoagulability in cancer, review risk assessment in cancer-associated venous thromboembolism, and review venous thromboembolism prophylaxis and treatment in cancer patients. I actually do have a little bit of history about this, which is, just to give a little bit of perspective, cancer-associated thrombosis has been recognized as a problem for many years. This is Armand Trousseau, who was a French physician in the 1800s and died about 150 years ago. He was the physician-in-chief to the Hôtel Dieu, and he made a number of contributions to medicine. And has several different things named after him, not least of which are Trousseau's sign of hypocalcemic tetany, and probably more relevant to this, Trousseau's syndrome. So he published a collection of his lectures in 1865, so 150 years ago. And the 95th lecture in this volume was entitled Phlegmasia albidolens, which translates to painful white edema, and more or less just refers to a DVT. What he said in his lecture was, this is sort of a long quote, I have long been struck with the frequency with which cancerous patients are affected with painful edema of the superior or inferior extremities, whether or not either was the seat of cancer. The frequent concurrence of phlegmasia albidolens with an appreciable cancerous tumor led me to the inquiry whether a relationship of cause and effect did not exist between the two, and whether the phlegmasia was not the consequence of the cancerous cachexia. In the rest of the lecture, he goes on to describe 3 patients who actually presented with VTE as their initial manifestation of either a new or recurrent malignancy. And so, it seems like he probably wasn't actually the first person to describe this, but 150 years ago, this is one of the earliest descriptions of a relationship between cancer and thrombosis. And you often hear that the Trousseau syndrome refers to a syndrome of migratory thrombophlebitis associated with cancer, but if anything, it seems that he was describing a more general relationship. The rest of his biography is actually pretty germane as well. 2 years or so after these lectures were published, he developed swelling of his own left leg, and a colleague and friend of his, Peter, later wrote about this. It was on January the 1st, 1867, when I went to give him my best wishes for the new year, that Trousseau told me with resigned sadness, "I am lost. phlegmasia which showed itself that night leaves me no doubt about the nature of my affliction. So he actually more or less diagnosed himself with Trousseau syndrome, was found to have a gastric cancer, and died of it in June 27, 1867, which I think is probably all the more reason why this deserves to be named Trousseau syndrome. In any event, we can move on to more recent data. Obviously, we know quite a bit more about this today than we did back in Trousseau's time. Some things that I think are worth pointing out. So, of all cases of venous thromboembolism, 20% and perhaps up to 30% are occurring in patients with cancer. And as Trousseau points out, for some of these patients, VTE is the first sign of their cancer. And so these patients are presenting both to oncologists, but they're also presenting to all of us. Cancer patients have a risk of VTE that is 5 to 6 times greater than the general population, and of all cancer patients, up to 10% or so will develop symptomatic VTE. If you look at rates of VTE at autopsy, the rates are potentially even higher than that, depending on the primary site of cancer you look at. And so, for instance, in pancreatic cancer patients, the rates have been reported to be up to 50%. I don't think it'll necessarily take too much to convince the people here that this is an important problem, but certainly I'll point out that there are significant clinical consequences. And so this here is a study of cancer patients that were hospitalized with neutropenic fever. And in this study, you can see that inpatient mortality in these patients is increased to 15% in patients with VTE, compared to 8% in patients without VTE. And this is true for both patients with metastatic disease and non-metastatic disease. Obviously, some of these deaths are occurring because of VTE. And studies show that VTE is the second leading cause of inpatient mortality in cancer patients. But clearly, this is not sort of totally cause and effect, and VTE is also acting as a marker for other comorbidities and general health status. That having been said, the increased mortality that we see in the inpatient setting also carries over to sort of post-hospitalization as well. This is pretty old data from the 80s and the 90s, but shows that the probability of death within 6 months of initial hospitalization was in the top bar here, up to 94% among those with DVT-PE and malignant disease, versus somewhere around 40% with malignant disease alone, and numbers less than that for DVT-PE only and non-malignant disease. Also, I think that the importance of VTE as a cause of death may be somewhat underappreciated. In one study, treating physicians attributed VTE to be the cause of death in about 3.5% of their patients, with cancer progression being the leading cause of death assigned. But again, this may actually be an underestimate, at least when compared to autopsy studies, which have shown somewhere in the neighborhood of an 8 to 20% rate of PE as the cause of death in our patients. In terms of trends over time, we know that the incidence of VTE, or at least the diagnosis of VTE in cancer patients, seems to be rising. And this is data from Europe and I believe the UK, where you can see that in 1997, the incidence of VTE was roughly 10 per 1,000 person years. And over time, that rate seems to have risen, and in 2006, it's something closer to 20 per 1,000 person years. You can come up with any number of reasons why this may be occurring. I think one thing is likely that as our treatments have hopefully become more effective, a greater proportion of these patients are living with advanced disease, and that's a risk factor for VTE. Certainly, over time, the trends in use of imaging have probably increased, and so to some extent, we're probably finding more cases incidentally that might otherwise have gone undetected. Even if that's the case, I think that these incidental clots or these asymptomatic clots may have some relevance. And one sort of line of evidence to that point is this study of patients with pancreatic cancer, where you can see that the top line, this is a survival curve, the top line is patients with pancreatic cancer without VTE, and they did the best. And patients with either symptomatic or asymptomatic VTE both did sort of similarly poorly. To move away from that, I'd like to spend a couple of minutes talking about normal hemostasis, because sort of understanding the mechanisms of hypercoagulability sort of understand what the defects in hemostasis are that are leading to thrombosis. One definition here of hemostasis is that it is a host defense mechanism to preserve the integrity of the closed high-pressure circulatory system. This system is normally inactive, but needs to be able to be activated quickly and carefully to minimize the risk of blood loss and minimize the amount of blood loss, but also so that clots form where we want them to and not pathologically where we don't. The basic steps of hemostasis are listed here. Formation of a blood clot requires platelet activation, adhesion, and aggregation, as well as blood coagulation. We sort of talk about these things as if they occur sequentially, and that's how I'm about to present them, but in reality, they probably are occurring essentially simultaneously. To start with the role of platelets. So the first step, obviously, is some kind of injury in the endothelium, and to be honest, I'm not so good with this pointer. Maybe I'll use this. So here we see a break in the endothelium. Here, which exposes subendothelial factors like collagen and like von Willebrand factor. Platelets have receptors that are able to adhere to these subendothelial components, and in so doing, they become activated. This activation leads to conformational changes in other surface proteins, including glycoprotein 2B3A, and that allows that glycoprotein to bind fibrinogen and von Willebrand factor, shown here in the bottom part of this top figure. In the second figure, what you can see are what you see essentially is platelet aggregation and formation of a platelet plug, where activated platelets then become cross-linked through these interactions with fibrinogen and von Willebrand factor. In terms of blood coagulation involves, I think, as we know, the sequential activation of proteases that ultimately results in the generation of thrombin and fibrin. And so this is initiated by the exposure of tissue factor, again after vessel injury, because tissue factor is sort of also expressed subendothelially in the adventitia in fibroblasts and in the media in smooth muscle cells. The intrinsic or the contact pathway is important for propagation of coagulation, but is not necessarily required for initiation of coagulation. So sort of a hopefully relatively simplified model of that is shown here. As I said, vessel injury exposes tissue factor subendothelially, and tissue factor complexes with activated factor 7A, which is actually present in low levels in the circulation on the surface of phospholipid membranes. And this complex of tissue factor and factor 7A forms the extrinsic 10-ACE complex, which causes activation of factor 10, which is shown here in the middle, to factor 10 to factor 10A. And that subsequently goes on to complex with factor 5A on, again, surface of phospholipid membranes to form prothrombinase. Prothrombinase causes the conversion of prothrombin to thrombin, and that results in the generation of fibrin from fibrinogen. Aside from activating factor 10, the extrinsic 10-ACE complex is also able to activate factor 9. Activated factor 9 is relevant insofar as it complexes with activated factor 8, and this forms the intrinsic tenase complex, which also can lead to the formation of factor 10 and then ultimately thrombin and fibrin. We know that the intrinsic tenase complex is actually 50 or 100 times more efficient in this process than the extrinsic tenase complex. Besides its role in the formation of fibrin, thrombin has multiple other activities, a few of which are highlighted here. One of them, and this includes activation of factors 5, 8, and 11. Just sort of one more time with a different diagram. On the left is platelet activation here, and essentially circulating platelets bind and are adhered to the site of injury via subendothelial connections with von Willebrand factor and collagen, and in so doing they become activated and then they aggregate and they cross-link. On the coagulation side of things, activated factor 7A is in circulation and binds to tissue factor that again is exposed after endothelial injury. This results in production of extrinsic tenase, and factor 10 can go on to form thrombin, and that results in the production of fibrin from fibrinogen, and again, in the end, you get a hemostatic clot. With that sort of covered in at least a little bit, I think we can start to go over a few of the proposed mechanisms of hypercoagulability in cancer. This is also a little bit simplified, but broadly speaking, there are sort of multiple pathways that are of interest here. We know that tumor cells are able to release procoagulant factors, and obviously I'll go into that in more detail in a minute. We also know that they produce cytokines and angiogenic factors, and that they express various adhesion molecules. And the release of procoagulant factors can lead to the direct activation of blood coagulation, and the production of cytokines and angiogenic factors, as well as the expression of adhesion molecules, can lead to activation of platelets, endothelium, and other cells, including other white blood cells. Ultimately, as with normal hemostasis, this leads to thrombin generation, fibrin formation, and cancer-associated thrombosis. I think the first obvious question, again, is sort of what are these procoagulant factors that are being released by tumor cells? Given what I just told you about the importance of tissue factor in initiating normal coagulation, it obviously makes sense to look at what role tissue factor could play in cancer-associated thrombosis. And some but not all studies have shown that tissue factor expression on tumors correlates with VTE rates. For instance, we know that most pancreatic cancers express tissue factor, and a study has also shown that patients with pancreatic cancers that express high amounts of tissue factor have a higher rate of VTE than patients with pancreatic cancer that expresses a low amount of tissue factor, 26% in this study versus 5% for the low tissue factor expressing pancreatic cancers. In another cancer, in ovarian cancer, it has also been reported that patients with VTE have higher tissue factor levels of expression compared to matched patients with ovarian cancer without VTE. That having been said, these are studies that are looking at tissue factor expression in the primary tumor. And as we know, these clots are not forming at the site of the primary tumor in general. I mean, sometimes they are, but certainly not necessarily. And so if tissue factor really is important, then one thing that we need to do is identify how it's circulating in the blood. And so Dr. Miller mentioned that the last time he went to a grand rounds about this was 30 years ago. I mean, this is actually sort of 30-year-old data that started to answer this question. So this was a paper published in Science in 1981 by Hal Dvorak and colleagues. And what they found in tumor cell lines was that these cell lines were able to release a substance with procoagulant activity into the cell-free supernatant. But that this activity was lost in the cell-free supernatant after a period of ultracentrifugation. They then found that they could recover this procoagulant activity by resuspending the pellets, and so they tried to figure out what was in the pellets, and by electron microscopy, they saw that these pellets were composed of plasma membrane-derived vesicles, or what we sort of now call microparticles. And so it seems like something on these microparticles is likely the source of this procoagulant activity. The same investigators published another paper in 1983 that basically suggested or strongly suggested that this circulating procoagulant activity was tissue factor. And so they identified that this procoagulant activity required factor 7A to work, which is obviously a property of tissue factor. They showed that it worked by cleaving tritium-labeled factor 10, which again is consistent with how tissue factor works. And so they tried to inhibit it, and they found that they could inhibit it with an anti-tissue factor antibody. And so this was really the first evidence that these tumor-derived microparticles contain tissue factor as the source of their procoagulant activity. This has been an active area of interest more recently as well, and one study shown here demonstrated that the presence of tissue factor-bearing microparticles in patients with cancer was associated with an increased risk of VTE. So in this study, the top line, again, so this is a graph of the cumulative incidence of VTE over time, and patients with presence of circulating tissue factor microparticles, this is a small study, but of the 16 of them, 4 of them developed clots. And of the 44 people who were not found to have circulating tissue factor microparticles, one of those 44 was found to have a clot, and it occurred something like 16 or 17 months following the time of that the assay was drawn. And so certainly this is suggestive, although I will say that there are other studies that have not been able to demonstrate this finding, which I'm not showing you. Aside from tissue factor-bearing microparticles, what are the other components that contribute to this? Clearly, one thing that's important is the activation of blood cells, leading to thrombosis as well. So we've discussed that platelet activation is important in thrombosis and hemostasis, and one thing that we know is that platelets can be activated through interactions with tumors. Recently, there has been a great deal of interest in the role of neutrophils, and specifically these neutrophil extracellular traps, which are composed of chromatin associated with histones and sort of granular antimicrobial proteins, and are released as part of an immune response to pathogens. Aside from a role in innate immunity, it's known that net release can also be promoted by inflammatory stimuli, which would include things like tumor secretion of cytokines, including inflammatory cytokines and GCSF. And nets have been shown to be prothrombotic. This is depicted here, so you can see down in the lower right, here's a neutrophil, and it's releasing this net, which again is comprised of essentially DNA and histones and associated proteins. And a number of sort of proposed mechanisms are elaborated on here. One is that nets are felt to be able to activate the contact or intrinsic pathway of anticoagulation via the activation of factor 12. Second, nets are felt to be able to recruit platelets and activate platelets through interactions with von Willebrand factor, which can bind to these nets, or through interactions with histone proteins, shown here. A third proposed mechanism has been that associated proteins, such as an enzyme such as neutrophil elastase, can cleave anticoagulants, such as tissue factor pathway inhibitor. And a fourth proposed mechanism has been that NETs can bind tissue factor, which is shown here, and that can lead to the activation of the extrinsic pathway of coagulation. Clinical data to support this is relatively scarce still, but again, this is sort of an emerging and an interesting story. Moving away from that, I wanted to review some of the risk factors for cancer-associated VTE development. Broadly speaking, we can divide these into patient-related risk factors, cancer-related risk factors, and treatment-related risk factors. In terms of patient-related risk factors in the bottom left, we know that increasing age and worsening performance status are risk factors for VTE. We know that obesity is a risk factor for VTE. Various and many comorbidities have been associated with VTE, and so that includes things like infections, lung disease, liver disease, kidney disease, heart disease. Tobacco use is associated. A history of prior VTE increases your risk of having a second VTE, and various inherited thrombophilias increase the risk of VTE in both the general population but also in cancer patients. In terms of treatment-related factors, there are a variety of these as well. So obviously we know that hospital stays increase your risk of VTE. We know that having surgery, and particularly sort of major abdominal type surgeries, can increase your risk. Many of the actual treatments that we give are prothrombotic, so that includes conventional chemotherapies like the platinum agents. That includes hormonal therapies or anti-hormonal therapies like tamoxifen. It includes anti-angiogenic agents like bevacizumab, and certain drugs that we use in myeloma as well. And a lot of our patients have central lines, and that clearly can also increase their risk. In terms of cancer-related factors, the primary site influences the risk of VTE quite a bit, and I'm going to show you a chart of that in the next slide. Having more advanced disease, so metastatic disease is associated with higher risk than non-metastatic disease, and certain histologic factors like higher tumor grade and having an adenocarcinoma as opposed to other histologies are considered higher risk factors. You can find various data on which cancers are the most prothrombotic, and different sources don't completely agree with each other, but this is European data from 2013, and this, at least based on this data, you can see that the highest risk cancers are things like pancreas cancer, mesothelioma, lung cancer, brain cancer, stomach cancer, and then it goes on down to sort of medium risk cancers, and then the lowest risk cancers, according to this data, are things like prostate cancer, breast cancer, and laryngeal cancer, although obviously I'll point out that these are still associated with elevated risk compared to this control group, which is at the very bottom. Based on what we know about these risk factors, various risk scores have been developed to try to help us to predict the likelihood that a given patient will have a thrombotic event. This is one of the simpler models that has been probably adopted kind of the most, and it was developed by Alok Khurana. It's really a pretty simple risk model, and you only need to know a few things about the patient to be able to score this, them. So patients get 2 points for having very high risk cancers, which are in this model defined as stomach cancer and pancreas cancer. Patients get 1 point for having a high risk cancer, which is lung cancer, lymphoma, gynecologic cancers, bladder and testicular cancers. And then you get various points based on your pre-chemotherapy CBC. And so having thrombocytosis gets you a point. Having hemoglobin less than 10 or being on erythropoiesis stimulating agents gets you a point, or having leukocytosis gets you a point. And then having obesity with a body mass index of greater than 35 gets you a point. People who have 0 points are considered low risk. People who have 1 or 2 points are considered intermediate risk, and people who have 3 points or more are considered high risk. This has been looked at in a few cohorts at this point, or actually several cohorts at this point, and the model seems to work reasonably well in a variety of different cohorts. In the original paper describing the model, which is on the left here, they found that patients with high risk, so 3 points or more, had a roughly 7% risk of development of VTE, which may not seem like all that much, except that the median follow-up time in this study was only about 2.5 months. So that's actually pretty significant. Patients with intermediate scores had a risk of about a 2% rate of VTE, and patients with low risk scores, meaning 0 points, had a less than 1% rate of VTE. As I said, this has also been looked at in different cohorts, and so on the right is data from the Vienna CATS cohort, where patients were followed for a longer period of time. And again, you can see that the score does separate people out into different risk groups. And so people with the highest risk scores of 3 or more had a roughly 18% rate of VTE at 6 months, compared to about 10% with a score of 2, roughly 4% with a score of 1, and 1.5% with a score of 0. In both of these studies, about 10% of people are falling into the high-risk category. So certainly it's not most of our patients that we are necessarily considering high risk. Moving on to prophylaxis and treatment. I'm going to show you data from a few studies on prophylaxis. So one study of prophylaxis was the PROTECT study. This study randomized outpatients receiving chemotherapy for locally advanced or metastatic solid tumors 2 to 1 to either a placebo group or a group who received nadroparin, which is a low molecular weight heparin, at a prophylactic dose for the duration of chemotherapy or up to 4 months. And this study included a total of 1,150 patients. In this study, what you can see is that nadroparin significantly reduced the rate of thromboembolism from 3.9% in the placebo group to 2% in the nadroparin group, which was statistically significant. And rates of major bleeding were 0.7% in the nadroparin group and 0% in the placebo group, which was not statistically significant. And so this is one positive trial for the idea of prophylaxis. Prophylaxis was also studied in the SAVE-ONCO trial, which had a reasonably similar design. So again, outpatients receiving chemotherapy for locally advanced or metastatic solid tumors were randomized 1-to-1 to either the low molecular weight heparin semulaparin at a prophylactic dose for the duration of chemotherapy or placebo. And again, the results are reasonably similar, which is to say they're positive, but maybe not necessarily that impressively so. And so semulaparin significantly reduced the rate of thromboembolism from around 3.5% in the placebo group to 1.2% in the semulaparin group, which corresponds to a hazard ratio of 0.36 and is statistically significant. Major bleeding rates seem to be the same in both arms at 1.2 and 1.1%. So, both of these studies are positive, and both of them show statistically significant reductions in thromboembolism. But that having been said, it's hard to be totally overwhelmed by this data. The absolute benefit from either of these drugs in these populations is clearly low, and in just an unselected population of cancer outpatients, the number needed to treat to prevent one of these events is 45 or 50. Semulaparin was brought to the FDA to try to be approved for this indication for cancer prophylaxis, and was actually rejected, which is why it doesn't exist. And so we have professional guidelines that are put out by the American Society of Clinical Oncology, and they recommend against the routine pharmacologic prophylaxis for cancer outpatients. I will say, though, that it does seem like these drugs are effective, And so I think one question is, can we find the right population of patients who might benefit from an approach like this? Can we identify a high-risk population that maybe we should be thinking more strongly about giving VTE prophylaxis to? And so multiple approaches have been suggested, and some are listed here, and I'll go through these. One idea is to use risk scores. One idea is to identify high-risk patients based on the site of their cancer, and one is somewhat more speculative, but to use levels of tissue factor-bearing microparticles. So one approach, as I said, would be to use some kind of risk score, and in particular, what's been proposed is maybe using this Karana risk score, which I showed you earlier. So this is an analysis, sort of a post hoc analysis of data from the PROTECT study. Again, when you look at what the risk scores of patients are, about 90% of them, or 1,035, about 90% of them are falling into a low or intermediate risk group, and about 10% of them are falling into a high-risk group. And so in the overall population, what I told you was that the reduction in thromboembolism went from 3.9% to 2%. But if you actually just look at the 10% of patients who had a high-risk score, the reduction in thromboembolism seems significantly more substantial, and goes from 11% in the placebo group to around 4% in the natriuretic group, in the low molecular weight heparin group. And so, that works out to a number needed to treat of somewhere around 15, which obviously, seems a little bit more attractive. And so that's one thing that we can think about. What else can we think about? So, the other thing we can think about is not using risk scores, but just taking patients with high-risk cancers and only giving thromboprophylaxis to them. And so this is data from, or this is the schema from the CONCO-004 trial, which looked at advanced pancreatic cancer patients who were on chemotherapy. Depending on their performance status and their creatinine, they got one of two regimens, which is not totally important to this discussion. But these patients who were given chemotherapy were randomized to either enoxaparin, which you'll see here is at a dose of 1 mg per kg per day, so sort of an intermediate dose of enoxaparin, or to observation. And then they were followed for the development of symptomatic VTE. And this is their outcome data from this. So the panel on the left shows the cumulative incidence of symptomatic VTE. And in the observation arm, this was 15%. And in the enoxaparin arm, this was lowered to 6%. And the risk of bleeding was not statistically significantly increased, and so bleeding risks were 7% in the observation arm and 8.3% in the enoxaparin arm. And so that's a thought as well. The last approach, which I said is sort of a little more speculative, would be to try to use tissue factor-bearing microparticles and use levels of those to decide who does or does not need prophylactic anticoagulation. And so, as far as I can tell, this has only been studied in one small trial where the investigators took advanced cancer patients with high levels of circulating tissue factor-bearing microparticles and randomized them 2-to-1 to either enoxaparin at a prophylactic dose of 40 milligrams a day or observation. Patients in the observation arm had a cumulative incidence of VTE at 2 months of 27%, and patients in the enoxaparin arm had a cumulative incidence of VTE of 5.6%. Obviously, these are small numbers, and the p-value for this was actually, I think, 0.06. So, again, it's interesting, and I think that we need to, if we're going to pursue this, then obviously it would need to be replicated in a larger study. And the other issue is that there actually is not a standardized way right now to measure tissue factor-bearing microparticles, and so certainly we would need that as well. But I think it's an interesting idea. So, while I told you that the recommendations are against the use of routine prophylaxis in our patients, they do sort of add this note that based on limited randomized controlled trial data, that we can consider low molecular weight heparin prophylaxis on a case-by-case basis in highly selected outpatients with solid tumors receiving chemotherapy. And then they sort of add this caveat that consideration should be accompanied by a discussion about the uncertainty concerning benefits and harms, as well as the dose and duration of prophylaxis in this setting, because in these studies use different doses. Well, I mean, exactly, these studies use different doses and durations, and it's really not totally clear how long you would continue prophylaxis. Although I think one obvious thought would be for the duration of chemotherapy. Let's talk about treatment. So the most important trial regarding treatment of cancer-associated clots was the CLOT trial. This study took cancer patients with acute symptomatic proximal DVT, PE, or both, and randomized them one-to-one to sort of a relatively standard treatment arm, which is with low molecular weight heparin with dalteparin for 5 to 7 days to bridge them to a vitamin K antagonist, so Coumadin, for a total of 6 months with a goal INR of sort of standard at 2 to 3, and randomize them and randomize the other arm to low molecular weight heparin alone with dalteparin for 6 months, initially at 200 international units per kg per day for the first month, and then 150 units per kilogram per day for the next 5 months. The trial reported a significant improvement in the dalteparin arm compared to the vitamin K antagonist arm, with a cumulative incidence of recurrent thromboembolism at 6 months for the vitamin K antagonist arm of 17%, compared to 9% in the dalteparin arm, which translates to a hazard ratio of 0.48 and is statistically significant, obviously. The bleeding rates in both arms were about the same at around 5%. So obviously, this and other studies similar to this show that the use of low molecular weight heparin compared to vitamin K antagonists are a considerable improvement in our patients. That having been said, I'll point out that a recurrence rate of 9% at 6 months is still quite high, and so I mean there's plenty of room for improvement here. But that having been said, this is sort of what we have right now, and so again, the guidelines say that the recommendation for long-term anticoagulation for treatment is low molecular weight heparin. Vitamin K antagonists are considered an acceptable alternative if low molecular weight heparin is not available. And then they sort of also note that they sort of say here that at least 6 months is preferred, but consideration of anticoagulation beyond 6 months is something to consider, particularly in patients who continue to be on chemotherapy or continue to have active cancer with metastatic disease. The last thing that I wanted to touch on is this issue of what about using novel oral anticoagulants in cancer patients. There clearly are a number of reasons why it would be attractive to use novel oral anticoagulants in our patients. I think for patients hate injections, I think is certainly one reason, and then fixed dose, no monitoring, that sort of thing. So certainly we know that in the general population that these drugs, the novel oral anticoagulants, are as effective and likely safer than warfarin, particularly in things like catastrophic bleeds, like intracranial bleeds. However, the evidence in cancer patients is, I would say, fairly lacking. Almost all of the available data on the use of novel oral anticoagulants in cancer patients comes essentially from sort of looking at the subgroups in the larger trials where the novel oral anticoagulants were studied against warfarin. And the cancer patients in these trials were underrepresented. So between 2 and 9% of patients in these trials had cancer, whereas what I told you when we started was, cancer patients make up 20%, give or take, of all VTE patients. And they were highly selected, meaning, that I think these were these essentially were healthier cancer patients than the cancer patients we actually see in practice. Because of various exclusion criteria in these trials, like abnormal CBCs and bleeding and things like that. And so it's not totally clear how representative these cancer patients would be, and how generalizable this would be to really the patients that would be seen in a general oncology practice. That having been said, meta-analyses have been done of these trials of novel oral anticoagulants versus vitamin K antagonists in the subgroup of patients with cancer. And here's a figure from one of them. And it shows basically that the data suggest that the novel oral anticoagulants are sort of as effective or maybe more effective. The odds ratio here is 0.63. So as effective or possibly more effective than warfarin. There are also sort of analyses of safety data, and again, they appear to be at least as good and possibly better in terms of bleeding risk. But as I said, I think there are really several things we need to consider before we apply this data broadly. One, as I said, is sort of how well do these patients really represent the patients we actually see in our practice. And two, and I think probably more importantly, is that this is all data of these novel oral anticoagulants versus warfarin, and so or against vitamin K antagonists. And so, this certainly may be some degree of justification for using these drugs when you're otherwise contemplating warfarin, but it's not necessarily justification when you're contemplating, using this versus low molecular weight heparin. And so, what we really need are trials of these novel oral anticoagulants versus low molecular weight heparin in both the prophylaxis and the treatment setting. And trials, those trials are actually ongoing, and hopefully we'll have more data to shed some light on this in the relatively near term. So again, what do the guidelines say? I mean, they basically say that right now, the use of these drugs, of the novel oral anticoagulants, is not recommended for prevention or treatment at this time. In conclusion, hopefully we have reviewed some of these alterations in hemostasis that increase thrombosis risk in cancer patients, and have reviewed some of these risk factors, both cancer-related, treatment-related, and patient-related, that can be used to predict VTE risk and have been incorporated into validated risk scores, which might potentially be used to identify a higher risk population for use of pharmacologic prophylaxis. Low molecular weight heparins are the treatment of choice for VTE in cancer patients. And lastly, in terms of sort of other things to look at, we really need cancer-specific trials of these novel oral anticoagulants, and we need data on how they compare to low molecular weight heparin. Thank you. I can't say that I'm familiar with data suggesting, for instance, that you use low molecular weight heparin instead of 5 to 7 days, you use it for like a month or something like that. I haven't seen that. I mean, it seems reasonable to think that that is probably better than only 5 to 7 days of low molecular weight heparin. Not to my knowledge. That definitely has been done, and I certainly cannot tell you that data right now. In general, so first of all, certainly there is data on how many of these are incidental versus symptomatic. So, in terms of lower extremity clots, most of the lower extremity clots that we find are symptomatic. People present with swelling and things like that. And also, we don't sort of necessarily routinely image the lower extremities. And so probably 70 or 80% at least of lower extremity clots are symptomatic that we find. PEs, the number of PEs that we find incidentally is a higher proportion, but still, I think, a minority when you look at the data. I personally treat incidental clots, at least DVT and PE, the same as I treat symptomatic clots, because certainly those clots have a tendency to propagate, and I worry about the risk of them becoming symptomatic. The area where that is less certain is not the extremities and not the lungs, but visceral clots. So, certainly patients with liver disease or pancreatic cancer or something like that, we will see splanchnic venous thrombosis not infrequently, and that is almost always incidental. And whether we should anticoagulate those people or not is more difficult to say, and it's sort of a case-by-case, basis, and I think that's a little bit trickier.
And one of the things that distinguishes those two high-risk tumors, pancreatic and breast, is they almost never respond. But if you take more responsive tumors, and those patients have a good response, is there tissue factor, exosomes, or whatever?
I don't know that has been looked at in detail. It's a good question, and I bet that they do, but I also think that we probably don't have that data.
Long-term cancer survivors, in my understanding of the literature, don't have an increased risk of CVC after their tumor.
I think that's true, yes.
Thank